So I'm going to cover some essential principles of radiographs, and then we're going to go through some of the technical aspects that are important. I'm going to suggest a systematic way of looking at chest radiographs, with the emphasis that there is really no right way. As long as you have a method that you can stick to and helps you interpret, it doesn't really matter. We'll go through some common important cases, and then there'll be a very non-scary quiz at the end with you can use the panel to make your answers. So starting with the basics of radiographs, different tissues appear different densities, and this is because they attenuate or absorb X-rays to different degrees. So air is black on radiographs, and this is because it doesn't absorb really any of the X-rays, whereas bone is white because it is highly attenuating. And then all the soft tissues in between will have different densities. If you sort of form a habit, you will avoid missing key areas. And this is the advantage of having a systematic way. It's always good to use two views if you have it. This is more important with orthopedic radiographs, but sometimes you're given both a frontal and a lateral chest radiograph. And if you see anything you're worried about, the first thing to do would be to compare it to previous ones. Or equally, if you have a CT or ultrasound, it's all useful information. So just to give you an idea of a comparison, a normal frontal chest radiograph has a dose, we measure it in millisieverts of 0.02. And this is equivalent to sort of walking around anywhere for 3 days. We're sort of exposed from radiation from outer space. Compare this to a lumbar radiograph, which is significantly more at 1.0, so sort of 50 times greater, and CT would be further still. So how many lung fissures can be seen on a frontal X-ray? Well, actually, sort of fewer than you would think. So on a standard frontal X-ray, often you can only see the horizontal fissure in the right lung, which is this red line here and this red line here. Whereas on the lateral, you can often see sort of overlapping oblique fissures. The green one is the right oblique fissure, and you can see that the hemidiaphragm on that side is higher than on the left. So this blue line is going to be the left oblique fissure. However, in practice, patient rotation may significantly alter the position of these, and also the oblique fissures aren't really linear like this. They're more described akin to aeroplane propellers. Going back to this one, just to say what these coloured markers are, this is going to be the right main pulmonary artery. This is going to be the left. This purple area is going to be the origin of the right upper lobe bronchus, and this the left upper lobe bronchus. And this is just to orientate you a little bit for when we look at some radiographs. So going through a few of the boring initial bits, sort of prepare the patient adequately, which is sometimes can cause artifacts on your study. So you want to remove all their clothing, their jewellery, putting their long hair up in a ponytail. You want to make sure you're identifying the right patient by their name, their date of birth, the date the X-ray is done. And these aspects of projection and technical adequacy, I'll go through by looking at a normal radiograph next. The indications for a chest X-ray nowadays are so variable. It can range anything from sort of query pneumonia to hemoptysis. It might be checking the position of iatrogenic lines. So don't be surprised if nearly everyone in the hospital ends up getting a chest x-ray as their initial point of call. So looking at this normal radiograph, if we think about projections, so this is a PA, or posterior-anterior radiograph, which is the standard one. They're standing, they're in full inspiration, and you can see the lungs and mediastinal outlined very well. If we have a lateral radiograph, it would be labelled with the side closest to the cassette. So if their left side is against the cassette, it would be called a left lateral radiograph. And that's particularly good at looking at the retrosternal and the retrocardiac spaces. Alternatively, an AP study, an anterior-posterior, generally is reserved for more unwell patients. It can be performed at the bedside with a mobile unit, and the patient may be either standing or erect. However, this has some disadvantages, namely that you get some magnification of the mediastinal structures, and this is because the patient is closer, there's sort of a shorter distance between the X-ray beam and the cassette, and therefore the beam diverges and you get magnification of structures, which, you know, makes them look bigger than they are in real life. In terms of, so that was projection, and then in terms of sort of other adequacy details, inspiration can be judged by how many ribs you can see. So these ribs that you can see curving around here, these are the anterior portions of the rib. And generally you want to see 6 or more above the diaphragm. You know, there's lots of reasons why the patient might not have been able to do that. The fact that they're in pain, you know, they might have real disease preventing them to take a deep breath in, or equally they might be confused and unable to comply completely with instructions. These lines here are the posterior aspects of the ribs, so the straighter bits you can see attached to the vertebral bodies at the back, that's going to be the posterior aspects, and generally you want to see about 10 of those. If you've got more than 10, it might suggest something like overinflated lungs, which can occur in something like COPD or asthma. Now looking at rotation, so the medial ends of the clavicles should be about equidistant to a line drawn right down the centre. That's how you know that the patient isn't rotated. A phrase I've heard talked about a lot is sort of turn to the dark side. So the hemithorax that looks darker is going to be the side to which the patient is rotated. This is an example of a well-centered film. And then in terms of penetration, this is a well-penetrated study. I can make out the edges of the vertebral bodies and the pedicles, which are these eyes at the side of each body. An under-penetrated film will look too bright, and you wouldn't be able to delineate the vertebral bodies like this. Or equally, an overexposed film would be too dark. However, nowadays, a lot of the sort of digital viewers can manipulate the windows. So, you know, this isn't as much of a problem as it used to be. So this is an example of a systematic approach. We'll go through each of these in turn. It's on the theme of Dr. A, B, C, D, E, with D in this case being diaphragm rather than disability, and E being sort of your exposure, i.e. everything else, which includes the iatrogenic lines, the great vessels, you know, can you see any surgical clips, any foreign bodies? But I stress that this is a method. Any systematic method that's useful to you is the right way to do it. So starting with A, airway, we want to see that the trachea is nice and central. These are the bronchi branching at the carina. So this is the carina here. There's several causes of deviation. Either something can be pushed away or it can be pulled towards. So I've got a question next, which I hope we can use the polling function for. And the question is, which of the following might cause leftward deviation? So you've got these options: right pleural effusion, right lower lobectomy, right pneumothorax, left lower lobectomy, or left hemothorax. And you need to choose A to E depending on which of these you think might be correct. If we just give it another 10 seconds or so, or maybe that's a bit mean, we'll give 15 seconds. Yeah, and if we see the answers now, that's great. So I can confirm that 44% of you are correct. But it was a bit of a tricky one because it was a bit of a, I was asking for a combination of answers. So thinking about pushing away and pulling towards, an effusion is a big amount of fluid in the pleural space, and it's going to push it away. So it would go to the left. So one is going to be correct. A right lower lobectomy would cause loss of volume on the right, and therefore you would actually get rightward shift. A right pneumothorax is the same principle as the effusion. It has mass effect with air in the pleural space. It's going to push it away from the right, i.e. to the left. So 3 is going to be correct. 4 is also going to be correct because it's pulling towards, and 5 would be the opposite. A hemothorax is just a bloody pleural effusion, so blood in the pleural space. So C is correct. Well, that's great. So now moving on to breathing. So if you want to ensure that the entire lung fields are seen, all the way from the apices to the costophrenic angles. So this is actually an example of an inadequate study. So as I can't see the extreme costophrenic angles, which might be important, it might not, but it's always worthwhile noting that the whole lungs have not been visualized. You can describe the lungs, referring to zones, but sometimes it's easier, referring to lobes rather, but sometimes it's easier referring to zones, so upper, middle, and lower. And this can sort of sometimes get you out of difficulty in pinpointing a lobe, which is not always possible. So you want to compare the lungs for any differences in their density. The hilar here represent it's a combination of the bronchi, the pulmonary arteries and veins. As you can see, the left hilum should be higher, or at a minimum at the same level as the right. And this is because the left pulmonary artery goes under the right upper lobe bronchus, so it's going underneath here, where it goes, it goes over on the left. Sorry, completely opposite way around, I meant. So on the left, the pulmonary artery goes under, whereas on the right it goes over. And this causes the right to be lower. If the left is lower than the right, it might suggest that either the sort of left hilum has been pulled down, or equally it could be that the right hilum has been pulled up. But hopefully there'll be other indicators on the film to suggest that. And also it's good to note that they have a similar density. These are normal hilar, so they both appear similar degree of whiteness. And this hilar point is concave, so it goes inwards. If you start getting sort of convex margins or very dense hilar, it might suggest some pathology, commonly lymph nodes which live at the hilum. This just shows that the lungs actually extend sort of beyond, the diaphragm that you're looking at. So you've actually got lung sort of going all the way beyond here. So, this is a good review area to look for any nodules. This costophrenic angle is nice and crisp. It's got a nice sharp point. If you start getting an effusion, you might get a meniscus level sitting here. And then in terms of the pleura, you can also get, as well as pleural effusion, you might get thickening. So you just want to trace it all the way along the edge. So cardiac size can be assessed on a PA film. And what you want is the cardiothoracic diameter, which is a ratio of the maximum cardiac size to the maximum transverse internal thoracic diameter. You want that to be less than 50%. So in this case, it is. Although it's going to be inaccurate on an AP film, an anteroposterior film, because of the reasons I described earlier about X-ray divergence, you can still assess it, and you can still ensure that the borders are nice and crisp. So on this side, the border is going to represent the wall of the right atrium. This is what you're seeing is a majority, sort of the left ventricle will be hidden in here somewhere. The left atrium, rather, will be hidden in here. This wall is going to be the left ventricle. And then looking at the mediastinum also, this is a normal mediastinum. You've got the aortic notch here. This is going to be the aortopulmonary window. If this starts getting widened, it might also indicate pathology. Again, it can be lymphadenopathy along the trachea, but also it could be sort of a vascular cause. So you'd be, a patient with pain radiating through to their back, you might worry about aortic dissection or aortic rupture. Great. D for diaphragm. The right hemidiaphragm is generally always higher than the left because of the mass effect of the liver. They're convex upwards and they've got a nice sharp border. If part of the dome is obscured, you might infer that there is pathology in the adjacent lower lobe, and this is known as the loss of the silhouette sign. This will come up again later, so I'll explain it a bit further. You also want to this comes into E a bit as well, but you want to see if there's any air under the diaphragm as well. Important review area. Sometimes it can be, this is just a normal gastric bubble, air in the stomach, but air under the diaphragm would track along its whole length, or may even result in a continuous diaphragm sign whereby you can see air along the whole aspect. And E for everything else, look at all the bones, so look at the clavicles, all the ribs, try and trace them round. You often get the humeral heads, the scapulae, the spinous processes. There's a lot of extra things that you can see. In the soft tissues, you want to be looking for things like swelling or air or foreign bodies, which might, if they've got clips in their axilla, it might suggest that they've had previous surgery. It could even be previous breast cancer. So it's all good clues as to what is going on. These 4 review areas people often have because they're places where things are commonly missed. People develop review areas based on their own experience, but commonly apices, the hilar, retrocardiac region, and below the diaphragm is where things hide. So it's always good to before deciding if something is normal or not, to look at these. Equally, there is an aspect of just stating the obvious. If there's a huge pneumothorax, just state that there's a huge pneumothorax, or if there's an elephant in the room, just state it. So you can start with that and then go back through your systematic way just to make sure you haven't missed anything big. Just a word on something I still sometimes get confused on is is the shadow in the airspace or in the interstitium. when we refer to sort of alveolar shadowing, we are looking at sort of abnormal material in the air spaces, and this may be anything from blood, pus, water, protein, or sort of cell debris in cancer. So sort of alveolar shadowing doesn't always mean infection. Whereas interstitium is the sort of the supporting structures, the scaffolding of the lung parenchyma, and it does give a different pattern of shadow. Reticular just means sort of, it's got a sort of a basket-like or mesh appearance. And these septal lines are sort of fluid or thickening of the septa between the lobules. With you might get a combination of patterns, so I think it's just always worthwhile just correlating it with the history, the exam, the lab results, so just using all your resources that you have available. So now we'll go through about, I think I've got 5 cases and then about 5 sort of quiz cases at the end. So starting with this one, I'll talk through this one to start with. So it's got the most striking abnormality is this unilateral dense opacification abutting the right heart border. So you've got more X-rays attenuated here. So you've got more tissue here. So you've got right middle lobe consolidation. In the context of fever and high CRP, it's most likely going to be infection. So this is a loss of the silhouette sign. So we can no longer make out the sharp definition of the right cardiac border. And there's sort of, it could be there's many cases of bacterial pneumonia, sort of the commonest being things like strep and H. influenzae. With this type of thing, it's nice to sort of suggest that the patient has a repeat chest X-ray in about sort of anywhere between 1 and 2 months' time, just to make sure this is resolved, because there might well be sort of an underlying cancer here that we miss underneath all this infection. So that was an example of right middle lobe obscuring the right heart border. If we go back to that case, if we couldn't see the left heart border, this would suggest that something is going on in the lingula, which is part of the, so the left, I'm sure, and you're sure you know this already, the left lobe, the left lung has 2 lobes, the upper and lower. The lingula is part of the upper lobe. It's sort of the equivalent of the middle lobe on the right. So this would, if you can't see this board, it would suggest lingular pathology. And equally, if you obscure part of the diaphragm, it would suggest lower lobe pathology, as I mentioned. But again, refer to zones if you can't work it out, and you can't always, you can't go wrong with sticking to zones. So if we use the pole function for this, I appreciate it's a little bit of a hard one. There's sort of several different differentials, but there is one sort of more likely answer. So if we give about 30 seconds. Great, and it's good that we've got a range of answers. I think it shows that it's difficult. I think that the unifying diagnosis for this one is actually pulmonary edema, and I'll go over why. So I think the sort of the most appropriate answer would be B in this case. So pulmonary edema sort of is fluid collection in the extravascular spaces, which causes impaired gas exchange. And the features of pulmonary edema on this radiograph are the heart is big. So if I were to measure the cardiac ratio relative to the internal thoracic diameter, it would be more than 0.5. You've also, it's a little bit subtle in this case, but you've got cephalization of the upper lobe vessels. So these sort of veins are all pointing upwards. And this represents increased pulmonary venous pressure. And you've got multiple opacities. This is mainly interstitial opacities in this case. So I'm not sure how well it projects, but you've got something called peribronchovascular cuffing in this case. So this, where my cursor is here, that is an airspace, and it's surrounded by a cuff of shadow. And that's basically, you're seeing a bronchus end on with sort of fluid around it. And you've also got septal lines, or also known as curly bee lines, which are these linear opacities at the side, which is also it represents interstitial fluid. You've also got alveolar opacity in this case, so you've got bat winging, which is sort of perihilar opacification, and you've also got blunting of the costophrenic angles. So they're not crisp. I can't draw a line around it, especially on this side. So it suggests a small amount of pleural fluid as well. So sort of the overall diagnosis would be edema. Pulmonary TB can cause miliary nodules. They're generally much smaller, so you get a very widespread appearance, but you get sort of tiny nodules everywhere. That would be the most, TB causes lots of different appearances, but that would be the most akin appearance, but it's not quite right for that. Metastases, again, tend to be more well-defined areas. Sort of, you get things like cannonball mets in renal cell cancer. You get multiple opacities you can draw around them, which you can't really, you can't really do that in this case. COVID-19, of course, is very topical. I think we have a danger of, especially at the beginning, maybe less so now, but we called everything COVID-19 infection or possible COVID-19 infection. But actually, sort of typical COVID-19 tends to be peripheral and basal predominant. We don't have that here. We have a significant amount of perihilar opacity, which is not typical. It might be indeterminate, but it's not the predominant pattern. And then left lower lobe pneumonia, I completely agree that you can't see the hemidiaphragm on this side. So there might well be some consolidation going on in this area, but it could also be accounted for by the pleural effusion, and it's sort of not the unifying diagnosis. It wouldn't explain everything else. So a hard one, but I thought it was a nice case in sort of trying to come to a conclusion to explain everything. Sometimes you can't, and you have to suggest several possibilities. You probably know this better than me, but the several causes of pulmonary edema can be cardiac in origin or non-cardiac in origin. Sort of notably, sort of non-cardiac, we see a lot of dialysis patients. If they've waited too long between sessions, they often, they can unfortunately present with pulmonary edema, haven't been offloaded. But it can be caused by trauma. We may have given too much fluid through a drip. It can also have central causes as well. So this case, I thought it was a nice case of, again, the silhouette sign. So on first glance, the abnormality is in this lower zone on the left. However, interestingly, we can see the heart border well. So we know that the pathology is not actually going to be in the middle lobe, it's going to be in the lower lobe. So this is right lower lobe collapse in this case. You can see the fissure nicely demarcated. You've also, sort of looking at lines, you've got a tracheostomy here, you've got an appropriate NG tube, and you've got clips here, so they've probably had some sort of abdominal surgery. There is mild tracheal deviation towards the side, to the right, which we would expect in a collapse. And also more subtle signs are, you can sometimes see the space between the ribs and compare that from side to side. There's less space between these ribs, they're crowded, and this is another sign that we've lost volume in this right hemithorax. I thought this is a good example of the sail sign, which can happen in collapse. So you've got depression of the hilum, so it's sort of hidden somewhere here. So you've maintained the normal configuration, i.e. the left is higher than the right, but the right is just too low in this case. It's been pulled down by this collapse. This is the sail sign, so you sort of can see this retrocardiac opacity obscuring the medial hemidiaphragm. All right, we've gone through this already using those cases, but so volume loss can be evidenced by rib crowding, an elevated hemidiaphragm, and sort of displacement or deviation of the mediastinal structures. And you also sometimes get upper lobe, if the lower lobe has collapsed, the upper lobe might look hyper translucent because it's overinflated to compensate for the loss of gaseous exchange that that has occurred by having that lower lobe collapse. Then thinking of causes, sort of, are you looking at something due to obstruction of the lumen, which could be things like mucus or an aspirated foreign body in a child? Are you looking at something in the wall, so something more sinister like a bronchogenic carcinoma, or equally an extrinsic compression by a mass? So if we use the pole function again, using our silhouette sign and other features, is there anything wrong with this radiograph? And if so, which lobe? Great. That's great. So the majority of you got the correct answer, which is the left lower. Don't worry if you didn't, it is hard. But in this case, you can actually, so the left lower lobe has collapsed. You can see a sail sign on the opposite side this time, this retrocardiac triangular opacity. With left lower lobe collapse, you might even get sort of a double cardiac contour, whereby you've just got sort of another line tracking where you would expect the left ventricle border to be. You've also got the hilum is actually a bit lower in this case, which again, we've got loss of volume here. And you can't see the descending aorta outlined very well. So great. Most striking abnormality is this big air space, which is going to be a big pneumothorax. You can't see any lung markings here. This is all just going to be pleural space air. And although tension is a sort of a clinical diagnosis, if someone's very unwell in A&E, they often, or they should just sort of treat, and that's sort of classically with a needle, second intercostal space, midclavicular line, and you don't see this chest x-ray because it's already been treated. But radiological signs of tension might be things like a depressed hemidiaphragm. So this looks a bit too flat. You may also have contralateral shift, which we can see here. We can see that the right heart border is too pushed across to that side, and the trachea is also being pushed across because of all this mass effect by this large pneumothorax. This is just an example. This is the British Thoracic Society. It's in their guidelines for treating, and it's just to show that how they treat them is a bit dependent on whether they think it's got a primary or a secondary cause, i.e. has it just happened spontaneously, or do they have something known to be wrong with their lungs. The size is important, sort of this 2 centimetre cutoff, and also whether they're symptomatic or not. I think this is quite a good guideline. I remember looking at it just to see like some of the thought processes as to why they treat or don't treat certain pneumothoraces. And this is, I thought, was a good case of surgical emphysema, which just means air trapped in the subcutaneous soft tissues, and it's sort of classically described as feeling like Rice Krispies or bubble wrap. Sort of, you can feel it all underneath the skin surface, and this might be a complication of the pneumothorax itself, or equally, if a chest drain has been put in and taken out again. And this final case before we get onto the quiz is, I just thought, is a good example of looking at lines. So sort of on first glance, you might think, is there much wrong really with this, this study? So we've got sort of an external defib pad here. The lungs look quite clear. I mean, unfortunately, you can't see the costophrenic angle on the right, so it's not quite an adequate study. But then if we come to looking at the rest of the tubes, this dark area is going to be the trachea. So the carina is going to be about here. This is going to be an endotracheal tube, an ETT. It's good that it's sort of between the clavicles, but another way of looking at that is how far it is above the carina. So generally the rule of thumb is about 5 centimetres plus or minus 2 above the carina. This probably is about 3 or 4 centimetres, so it's going to be fine. It does depend a bit on the position that the patient's head was in when they took the radiograph in the first place, because as the neck is flexed, the ETT is going to sort of descend further down. So if it's sort of too far sitting here, there's a risk that it would sort of selectively inflate one bronchus only, and you'd want to retract it back a bit to be safe. This is going to be an NG tube, and actually if you follow it around, you can see that it actually coils at the gastroesophageal junction and then goes back on itself. So the tip is actually within the mid-esophagus, and this would be an important thing to alert the team for. So it either needs to be sort of pulled back and reinserted, or sort of another attempt made, but the tip needs to be below the diaphragm. And then looking at this case, NG tube, in this case, it should bisect or cross the carina. This does not. This passes down the right main bronchus, and you can see it sort of lies somewhere in the right lower lobe. So this is something that you would want to tell them immediately, or even sort of pull it out in the X-ray department. This is not safe to use. It has to be taken out, otherwise you're going to feed this person stuff into their lung and cause sort of a horrible pneumonia. Right, so it should be crossing, descending in the midline, passing below the hemidiaphragm. That would be a good position for an NG tube. So if we go to some quiz cases, honestly, it doesn't matter if you're right or wrong. It's just nice to have a go. There's really nothing silly you can say or not say. Some of the aspects I've covered. Some of the aspects are new. So don't worry. So this 65-year-old with a significant smoking history has breathlessness and chest pain. What is the most sort of worrying finding? All right, so if we have a look there. Great. I mean, I like the fact that there's a range of answers. Because there's several sort of things going on here. Um, the most salient thing is actually they've got bilateral pneumothoraces, so which is D, and I'll show you that here. This is the lung edge on the right. This is just black air in the pleural space. So this is going to be pneumothorax on this side. And then equally on the opposite side, I hope the poll isn't obscuring it, but do just write in the chat if it is. There's also a pneumothorax on the left as well, so in the apical segment. This person has bilateral pneumothoraces. They don't have tension, so the trachea is quite central. The mediastinal structures are where they should be. It's not the only diagnosis though here, which is why it's a bit confusing. They do have emphysema, so which is B. So you can see sort of these large air-filled bullae, most notably here and also in the upper lobes. And the lungs are generally sort of quite overexpanded, so the diaphragm is very flat. In terms of the other diagnoses, I think right upper lobe mass would be here. There's not really increased opacity in this region compared to this region. Bibasal atelectasis, I mean, yes, there probably is a sort of these linear lines tracking here and sort of linear lines here, but it's not really surprising if they've got these pneumothoraces that they would have a bit of underlying collapse. This is an 81-year-old with cough, weight loss, and a left-sided Horner syndrome. So this tumour has a particular name, which I'll go over after, but sort of what are the symptoms it may cause? Great. So if we go over their answers now, this is a bit of a, it's not a trick one, but great. All of the above. So it can cause any of these. And so this is an example of something called a Pancoast tumour, which is just a name for a tumour in the superior sulcus. And it does often invade the surrounding soft tissues. So Horner syndrome is that combination of hypohidrosis, so lack of sweating, meiosis, a small pupil, and partial ptosis. And it's due to disruption of the sympathetic chain, which is going to be running down here. It can cause any of these things. So it may cause obstruction of the SVC, which is manifested with things like facial swelling, cyanosis, dilated neck veins. It may invade into the brachial plexus and chest wall and result in pain, as well as sort of atrophy of the small muscles of the hand. And it can involve the left recurrent laryngeal nerve because it has a longer course around the aortic arch. So all of the above. Looking at this mass, sort of masses can be hard to describe sometimes, but common things for any mass, it doesn't really matter in terms of whether we're talking about radiographs or CTs or where it is, but good things to describe are things like where it is, how big is it, so we can measure it, what shape is it, i.e. sort of is it diffuse, is it affecting the whole lung, has it got spiculated sort of margins, is it well demarcated, so can you draw a line around it? This is actually a little bit fluffy, it's sort of I couldn't draw a pencil around the whole thing. How dense it is, and its texture. So is it sort of uniformly white, or is it got bits of heterogeneity, for example, if it's got little bits of air in it, it might suggest that it's cavitating and necrotic. All right, and again, you can see this is quite a striking tumour, but if it was more subtle, it might just be seen as a slight increased density in this apex compared to this side. So again, sort of always look at the extreme of your film. Other things on this study is just that to note, not as significant as the tumour, of course, but you can't see the left costophrenic angles, so we don't know if there might be a little effusion or something there. And also, this is just an example of unfolding of the thoracic aorta, so it's not neat and contained in here. It's gone quite far out. It just happens in older people. It's not surprising. An 81-year-old, it doesn't have any significance in itself. So this 45-year-old has right shoulder tip pain and quite a distended abdomen. What should we do next? Great, if we have a look at the answers. Great. We're going to alert the surgical team, and I hope that why people are doing that is because of this pneumoperitoneum, so i.e. air in the intra-abdominal space. So this is an erect study, gas rises, it sits in the sort of subphrenic region, and it means that you can see air below the diaphragm. And it suggests that there's a perforated viscus. I won't steal Jack's thunder, but this could be anything from a peptic ulcer disease to diverticulitis, appendicitis. Although not all pneumoperitoneum needs to mean that something has perforated, it could happen due to us ventilating the patient too vigorously. It just could be that they've had intra-abdominal surgery and this is a normal expected finding. So it's good to always have some history. But yes, in this case, we'd want to tell the surgical team. And they're very likely to want to do a CT abdomen and pelvis. So I've got two more cases. This 40-year-old is got a cough, bloody sputum and a fever. I've done that classic thing of doing what you're not supposed to do, of what is the least likely diagnosis. So 4 of these are potentially correct and 1 is less likely. If you don't know some of the words, empyema, it just means sort of an infected pleural effusion. Great, so we've got a good range of answers again. The least likely one is that one I mentioned, empyema, and that's because an empyema or a pyothorax is it normally it's in the pleural space, so it's going to have a lentiform shape, sort of tracking along the rib cage, and it's going to have sort of what we, it's classically described as having obtuse margins with the rib cage, whereas this structure has an acute angle here and an acute angle here, so it's not going to be within the pleural space. So any of the others are possible. I think this case was actually presented as a lung abscess. So you've got this round cavity with an air fluid level, and that's due to it's got a mixture of pus and other muck in there, which can, is probably is obviously much rarer than just a simple consolidation, but it can happen in people with immunocompromise, for example, if they've on chemotherapy or if, for example, if they've got HIV or someone malnourished, or this could actually be, if they've got emphysema, it could actually be an infected bulla. I don't think this person does, because they've got normal sort of appearance of their lung markings elsewhere. But all the others are reasonable as well. It could be sort of a horrible cavitating carcinoma or a necrotic metastasis. So the least likely is an empyema. I'll show you an example of an empyema, which is this. So you can see this left-sided biconvex pleural collection, this obtuse margin that I was talking about. And the last case, a 55-year-old with breathlessness and weight loss. So this is a hard one, and admittedly one of them that I didn't cover in the cases earlier, but this is actually a different type of collapse. This is going to be a left upper lobe collapse, and this is described as sort of a veil-like opacification, which extends out from the hilum, which is sort of why it's a bit denser here, and it becomes sort of sheet-like and obscures the heart border, which we know is adjacent to the lingula and therefore the upper lobe. You've also actually got some evidence of mass effect in terms of it's being pulled towards this side. So the trachea is pulled also towards the left, which just indicates a volume loss in this side. And indeed, if you sort of draw around the lung, it is just generally smaller than the other side. There's also, this is called sort of an air, I can't really pronounce it well, it's called a Luftischl sign, an air crescent sign, Luftischl, and it's just due to the overexpanded apical segment of the left lower lobe. So the left lower lobe is actually fine, somewhat underneath this, but it's sort of positioned between the collapsed upper lobe, which is all this veil-like opacity, and the aortic arch, and you get this this crescent affair around it. Once you see collapse, it's easy to stop there, but it's a good thing to sort of think, why do they have collapse? So actually, if you look more closely, I'm not sure if I can convince you or not that there is actually a mass here, and this was actually due to an obstructing bronchogenic carcinoma resulting in collapse. So this, once you see collapse, think of why. It could just be mucus, but especially if it's not resolving and they've got weight loss, they've got red flag symptoms, think about why. So great, thanks a lot for doing the questions so well. So in summary, sort of have a systematic way of looking at these radiographs. Normal chest radiographs are actually the hardest, in terms of, to say that something is normal and has no abnormality can sometimes be braver than identifying small abnormalities. Use the information they give you. So, if they appear septic, the consolidation you're seeing is more likely to be infection than blood, whereas if they've had trauma, you might think more along the lines of blood. So use it to your advantage. And there's sometimes not one right answer. They might need follow-up imaging. They might need a CT. So sometimes you can't get all the information from a chest radiograph. It's all there, but can't be interpreted to reach one unifying diagnosis. And these are some of just the reference of the things I use to help me. Radiopedia is a great resource for myself and for when I was in medical school as well. It's got a huge amount of great cases. This chest x-ray book is good if you're a foundation doctor. And I remember using this book in medical school as well. It's sort of a big pink book with lots of good simple explanations in. So thank you very much for listening.